Good morning, everybody. Please join me in welcoming our plenary speaker, Dr. Mary Fallat. Dr. Fallat is the current Vice President of the American Association for the Surgery of Trauma, the EMSC Program Director of Kentucky, and is a pediatric trauma surgeon at Norton Children's Hospital. Welcome, Dr. Fallat. As always, please put any questions or comments in the chat and we will address them at the end of the presentation. Thank you.
Hello, everybody. It's my pleasure today to talk to you a little bit about a project that I've just completed. And in the course of the next few minutes, I will tell you about the Childress Foundation and how I decided to do this particular project. I have only one conflict of interest in that I am funded as Program Director for Kentucky EMS for Children. And the objectives of this talk are to tell you about the deficiencies in pediatric trauma system development in the United States emergency care system. I will review again what it means to be pediatric ready, but specifically within the context of trauma, and describe some ways that non-pediatric trauma centers can begin to approach gaps in trauma care for children. These are the contributors to this study, including myself. Amelia Collins is a surgery resident who's doing some research at Indiana University, and she's really helped with the lion's share of this work. The others that are listed have all had considerable parts in what you're about to hear. Trauma system development actually began many years ago, and it was organized by Richard Mullins of Oregon. He's a trauma surgeon, now retired, who was also one of my professors at the University of Louisville. Frida Holka is now a trauma pediatric and acute care surgeon in Reno, Nevada, and she was doing a research year with Dr. Mullins during the time of what was called the Skamania Conference on Trauma System Development. She actually wrote the very first paper on pediatric statewide influences in trauma systems. This is the abstract from her paper that was published. And basically at that time, Oregon and Washington, next door neighbors, were different in that Oregon had a trauma system, Washington did not. And of interest, they found that seriously injured children in Oregon demonstrated a reduced risk of death consistent with benefit from the statewide trauma system. I was privileged, along with others from EMSC, such as Marianne Gaushi-Hill, to participate in the project, The Future of Emergency Care in the United States Health System. And we were part of the pediatric subcommittee. That report, which painted a picture of both adult and pediatric acute care in this country, showed that the variation in preparedness for children was extreme. Only 6% of the emergency departments in the country at that time had all the supplies deemed essential for managing pediatric emergencies, and only half of hospitals had 85% of these. There was generally a lack of care coordination, geographic disparities in access to care, etc. Out of that particular project was born Pediatric Readiness. But in addition, there was an effort going on in the trauma community through the Childress Institute of Pediatric Trauma. This institute, which was the brainchild of the Wake Forest University and funded by Richard Childress, who is actually a NASCAR driver, started out with $10 million of endowment specifically for pediatric trauma. There were two summits. I was pleased to participate in both. And at the first, which was reported in the Journal of Trauma in 2013, there was just an overview of all the gaps in pediatric trauma care in this country. But the second was more focused. And during that one, we came up with 3 specific projects that were worthy of attention that might propel pediatric trauma forward in this country. One was to specifically look at the development of pediatric trauma system care in this country. And so I applied for and was funded by the Childress Institute to develop a contemporary national report on the status of pediatric trauma system planning and development, which I hoped would inform trauma care as well as enhance further research in this country. In terms of background, I don't know how many will remember that trauma system development was actually funded in this country for a short time. It started out in the EMS for Children program as a supplement in 2001 through 2, and then there was a request for proposals through HHS. And Kentucky was actually funded for a grant. However, after 1 year, the federal government pulled that funding. This conference of state legislatures, along with the Committee on Trauma of the American College of Surgeons, was one of the first to look at adult trauma system development in this country. And that was in 2006. About 10 years later, the National Association of EMS Officials looked at it again and updated it. And that report, which is very robust, only included 2 or 3 questions on children. Simultaneously, in 2017, the General Accountability Office issued a report on pediatric trauma centers, which gave us a lot of information on trauma centers and where children live in proximity to these and the resources they provide. However, it did not put that in the context of trauma system care. So these were my 2 starting points. The GAO report covered the years 2011 through 15, and what we learned is that almost 60% of the 73 million children in our country during that time lived within 30 miles of a pediatric trauma center. However, in 8 states, there were no children who lived within 30 miles of a pediatric trauma center. And in 15 states, only a quarter lived within that range. We also knew that even in states that designate trauma centers, nearly half of injured children are treated at non-trauma centers. These are depicting a map from that GAO report. I'm just focusing on this for a minute. This depicts children who live within 30 miles of a high-level pediatric trauma center by state. A white box means 0 to 25% live within that range. A dark green box means that most of the children live within that range. And at the upper right is the Trauma Information Exchange Programs map at about the same time, which shows where level 1 and 2 pediatric trauma centers are located. You can see the maps pretty much overlap. I also wanted to just point out that in the GAO report, they looked at under 18, and in the ATS report, they looked at under 14. The age of a child is not consistent between reports and studies, and I don't think it ever will be. Further maps from the GAO report showed that as you increase the trauma center vantage point to high level adult or pediatric, or subsequently all levels of trauma center, there is increasing penetrance of the ability of a child to be located in proximity to a trauma center. So this is, at the bottom here, is all trauma centers in the country. And you notice that there are no longer any white areas. And so there are lots of kids who are close to a trauma center, not necessarily a pediatric trauma center. You've all seen this before, and this is the chances of an EMS provider treating an individual child, which is fairly low, comparatively speaking. And it is lower if they're in a rural or underserved area of our country. I wanted to show you one slide about the pediatric surgery anesthesia workforce because it's pertinent to our discussion also. So in this upper left map, you see that this is where pediatric surgeons practice. Again, the white areas are where there are few of us, and the dark green areas where there's a high density. And approximately 40% of pediatric operations in our country are actually done in adult general hospitals. Here's this trauma center map you're familiar with, and here's where anesthesia practices. These are divided into hospital referral regions, and 10% of the pediatric population lives in an HRR without a pediatric anesthesiologist, and 23% without a pediatric surgeon. So methodology, we developed a spreadsheet with data from everything we could call from the NSEMSO and GAO reports that we thought were remotely related to children's trauma. We then developed a relevant survey that looked at what we didn't know. We used the American College of Surgeons psychometrician as a guide to help make sure we were asking the questions appropriately so they could be answered. And then I deployed the survey to these 4 groups in each state: the state trauma managers, EMSC program managers, and state EMS directors are all within NSEMSO. And then the American College of Surgeons Committee on Trauma State Chairs was the last group, and the COT helped me with that list. We developed 2 documents. One was the spreadsheet with all of the data from the 2 reports, and we asked people to look at that and tell us whether they thought that information was correct. And we also sent a survey monkey just to these 4 people. We asked them to work together and for one person to enter the data so that we would not have conflicting data from the state. The survey was deployed. We had many return, but not all, so we kept trying. We did discover respondent-related limitations of the methodology. What that really translates to is several people didn't read the directions, and so we had 2 or 3 responses from each state, and the answers were different, and then we had to reconcile them. This is the preliminary timetable, and it took us about 2.5 years from the start of the project to the point where I had most of the data returned and had been able to reconcile the data. Then we asked a 14-member team of representatives from sectors in pediatric trauma care to participate in a Delphi process where we would determine metrics that were most important in pediatric trauma system development and come up with a scoring system to use for each state. These were the contributors. I'm not going to dwell on this, but basically I tried to include somebody from every sector that had a vested interest in trauma care. And if I didn't know someone, I asked their organization to supply me with a name. Or if I did know people, I asked if this would be a good person. These are the 6 domains we came up with, and you can see the scores on the right. There were 5 different sessions as well as a conference call to reconcile all of this. And I'm going to talk a little bit about each domain and the metrics within it. So for the disaster domain, we looked at state disaster plans, whether they included children, whether there were drills and did they include children. And we looked at surge and whether there was a capable way of managing surge and identifying hospitals that could provide care for children. Under legislation and funding, we looked at the state legislation. We actually went to the statute. We looked to see if they mentioned children, if they had pediatric representation on their trauma advisory council. We looked at whether the legislation was granular enough that it was helpful in designating centers, that it addressed planning, simulation, and modeling, et cetera. And then lastly, we looked at whether there are any state funds for pediatric trauma care. Under access to care, we looked at the current field triage guideline, whether it was used. We looked at whether there was a destination determination for pediatric trauma patients. And then we also looked at rehab and burn beds, and we used some of the GAO information to determine how well that state could function in terms of access to care for pediatric trauma patients. For injury prevention and recognition, we looked at child fatality review, child abuse, and whether the state and trauma centers were aware of it and were looking at it. Under quality improvement and trauma registry, we looked at summary data from the trauma registry, whether it was public, whether it included pediatric reporting, and whether it was used for performance improvement. And we did the same for EMS. And then for pediatric readiness, we looked at whether the state participated in the last survey and whether there were transfer guidelines and protocols in place. And we also looked at ALARA, although that was a little bit of a gap that needs to be further investigated. When we finished, we tried to decide what to call our score, and we ended up with the last Pediatric Trauma System Assessment Score. In updating our timetable, we're now at about a year and a half ago. We had gone through the Delphi process during that time. We scored the states initially. And then we started to look at a few more things like missing data and whether we were really happy with the data that had been accrued or whether we should try to get some of that missing data. And so Amelia Collins and I went through each state. If we didn't have a metric answered, we went to the web and tried to find information about it and come up with some type of documentation for that so that we could make sure that we were giving every state the benefit of the doubt. And then we finalized our state abstracts. There's about 88 data points per state, and now we're working on our final report in a manuscript. And so because of all these different questions and answers, we came up with a coding key. Anything that was green came from the GAO report, blue came from that NSEMSO report that you saw. If it's orange, it was our question or an updated answer from the NSEMSO report. And then anything that's highlighted was included in the Delphi scoring. So each of you who are watching this will get a state abstract that's 3 pages long, and that will have all of this data that we were able to put together. And I put North Carolina up here because that's the origin of the money that helped fund this project. I'm briefly going to go through just a little bit of the information that we obtained. I will also say that in September, I will be giving a similar webinar for NSEMSO because their officials who aren't participating in this today also would like to hear about the report. And then I will be coming to the NSEMSO meeting in Reno, assuming that takes place. And hopefully at that point, we can drill down to some of the other information that you'd like to have. And so of interest, 49 states do have trauma system legislation. The only state that doesn't is Vermont, and the District of Columbia does not. Children are addressed in the state statute in 40 of these states, and these are the states where children are not addressed in the state statute. There are trauma advisory councils in all of the states that have trauma legislation except for Missouri, and of those, 32 have specific pediatric representation. And this is a list of the states that do not have pediatric representation, at least documented in their state statute. We also looked at destination determination. On this slide is actually depicted whether or not the state has a pediatric trauma bypass protocol, and you can see this is evenly divided. This map shows CDC field triage guideline use. Yes means they're using it without modification. A blue is yes, they're using it, but with modification. And the orange states, they are not using the field triage guideline. They're using other guidelines, or there's no state mandate. On the left is trauma destination bypass. So this is adult and children, and you can see that most states do have some type of trauma destination bypass protocol in addition to the field triage guidelines. And then on the right, the state pediatric trauma destination, yes is red, no is blue, and the golds did not respond to the question. This slide relates to injury prevention and child abuse. And we looked at whether there was a mandatory death review of all childhood deaths, child fatality review legislation. We also asked whether the adult trauma center emergency departments had guidelines for recognition of child abuse. This graph depicts those questions. You can see in red that most of the states do have trauma center guidelines for recognition of child abuse. Most have state legislation for child fatality review that is instructive on child abuse. Most have a mandatory death review of childhood deaths resulting from abuse, and some even have specific shaken baby parent education legislation. This looks at PI plans. This is all information you can get from the web. So we looked at whether the state had a PI plan for trauma and whether it was whether children's interests were recognized. And you can see here that most states do have a PI plan, and children are recognized in most. We also wanted to see how many states have their trauma registry electronically integrated with pre-hospital EMS data. There is a movement towards this, and these are the states that already have some linkage. This question is probably one of the most important and is probably the one that also illustrates the biggest gaps. It asks whether children are typically worked up at the referring hospital or whether there's a discussion and they're transferred and minimal workup is done, at least to get them to the next location. It also asks about telemedicine and teleradiology sharing capability. And it lastly asked about the use of ALARA, which is as low as reasonably achievable guidelines. I'm sure that there are individuals who are watching this who are as frustrated as I am when an adult trauma center does a man scan on a baby or a small child. That is a lot of radiation, and most of the time it's unnecessary. And this is reflective in this principle, not only of making sure that the children only get what they need, but also making sure that the radiation use is according to guidelines. So let's talk a little bit about pediatric readiness in trauma centers. You're all familiar with this study and with the fact that we're undergoing another survey, and that high volume hospitals typically have a better pediatric readiness score. And you're all familiar with the fact that there's a checklist that helps you identify how well the hospital is performing and be able to benchmark that. This is a study by Ames that showed that if you have a higher pediatric readiness score, you have a lower mortality risk for children who are critically ill. This is critically ill, not injured. There were two studies that looked specifically at trauma verification. One was published in 2015, and within that report, there was a California assessment of their trauma centers and their non-trauma centers. And if the center was a non-trauma center, they had a score of 68. And if it was a trauma center, they had a score of 65. And this should be actually level 2 and level 3 and level 4. Level 1 and level 2 trauma centers did well, and the pediatric centers, of course, did well. And so this study showed that if you were a trauma center and you were a level 3 or 4, you didn't have a better pediatric readiness score than a community hospital that didn't take care of trauma patients. And then this study, which was published more recently in 2019, and these were self-identified trauma hospitals, showed pretty much the same thing, that if you were a lower level trauma center taking care of mostly adults, your pediatric readiness score was not much better, or it was lower than community hospitals. I've always made the claim that children who are injured should be taken to a trauma center, but if we can't say that the pediatric care would be better in a trauma center, I'm not sure that we can make the claim that that's where they should be. When we looked at the metric for this particular study, Dr. Remick met with our group, and we thought that we should look at engagement rather than the total score. So engagement was defined as more than 80% participation by the hospitals in the state, which meant that they took the time to do the survey and to evaluate their pediatric readiness and to appreciate what it meant. We also looked at transfer agreements and protocols, and this is really intriguing to me, but 14 states said that their hospitals did not have transfer agreements and protocols, and these were the hospitals that answered no to that particular question. There is a course offered through the Committee on Trauma called the Rural Trauma Team Development course that has a small chapter on pediatric trauma. 34 states currently offer this. The next thing we did was create some pivot tables. I'm not sure how many of you are aware of how many regionalization schemes there are in this country. But first, looking at the bigger map, these are the scores for the individual states. And the first one you're looking at is regionalization for EMS for children. So we regionalized the states based on what organization we were looking at and came up with scores for the region, which ultimately could help us with some additional modeling and for the organizations to focus their care in specific regions. The Committee on Trauma has different regions, so you can see them depicted on this slide. This is the NASEMSO regionalization, and as you can see, some of their regions are much larger because they have fewer regions. And then this is the US Census Bureau, and I'll tell you why that's important in a minute. So the US Census Bureau relates to a Wonder database to assess correlation with state injury mortality. And once we made up our scoring system, we made an effort to at least initially determine if it had some validity. This Wonder database looks at mortality rate of children under 18 by state, place of death, in hospital and out of hospital. And so we did a linear regression analysis correlating with mortality to see if our scoring system had any relevance. And actually we found that for each 1 point increase in our score, there was an overall decrease of 0.12 per 100,000 children in overall mortality, and a decrease of 0.06 for in-hospital mortality. These were both significant, and the out-of-hospital came close to significance, but did not achieve significance. So what are the opportunities going forward? Well, first, I wanted to show you on the left where all of our adult level 1 and 2 trauma centers are compared to pediatric trauma centers. So we have a lot more adult than we do pediatric trauma centers. But this is rather stunning, which shows the level 3 and 4 trauma centers in this country. There are certainly a lot more of them. So this is an untapped opportunity to help take better care of kids in our trauma centers. And then on the bottom, currently, there are very few level 3 or 4 pediatric trauma centers. You can see little cluster in Washington State and a couple in Texas. So future directions, each state will get its own report or its own 3-page abstract. We are going to also validate our scoring system with HCUP data. We've purchased that database for 2016 to 17, which is the main years of this report, and hopefully we'll have that evaluation done soon. We have this sort of fancy database in real time that's capable of updates, and hopefully at some point we can operationalize that. We could potentially offer regional development grants, maybe through EMSC at some point as targeted issues to help regional development by asking well-resourced states to help less well-resourced states improve their care for kids. And then I'm hoping ultimately there'll be some trauma metrics that will come out of this that could be used for system reviews for the Committee on Trauma's trauma system evaluation program. Our deliverables, by the end of the year, hopefully by the NASEMSO meeting, you will have a downloadable PDF of this information, and there will be some printed copies of the book that will go to the people who contributed to the study, the EMSC program managers, trauma program managers, et cetera. And much of the information is updated from the last NASEMSO report. So I feel like we've made an effort to try to get the best data for you that's reasonably contemporary. The report will be about 250 pages, and again, hopefully will be done by the time of the NASEMSO meeting, and we have a manuscript about ready to submit. So with that, I'll conclude. Hopefully there'll be a little bit of time for some questions and answers, and thank you for allowing me to give you this presentation today.
I'm going to give everybody here a second to put some questions in the chat. We had a couple come through. Looks like one of these came. It says, Dr. Fallat, are these data or will these data be publicly available to patients and families? If so, where and when?
Yes. So the PDF should be publicly available also, ultimately, once it's ready by the end of the year.
Okay. Another question that came through is, how can non-pediatric emergency rooms, trauma centers, medical professionals become prepared for trauma events involving children?
So I sent a few extra slides that we might put up for a minute, and I'll just give you some thoughts.
These slides are
I'm not sure if others can see the slides. I actually can't see them, but
they are in.
can others see the slides? Because I can just look at them on my side.
Yes.
Okay. Give me a minute and I'll pull them up on my side. So you are hopefully looking at a slide that talks about ways for trauma centers to prepare for being pediatric ready. And I think that this is a challenge in terms of the gap between the team that takes care of trauma patients and the team that's actually in the emergency department. Putting this into perspective, the Pediatric Readiness Survey would be done by the emergency department staff. They can go to the Pediatric Ready website, do the survey, compare their emergency department to the state. They can do a gap analysis. They can go to the toolbox and see what needs to be done to fill those gaps. They can appoint a nurse and an MD to be their pediatric emergency care coordinators. This conceivably could also be the trauma director, the trauma program manager, but it also could be somebody who is in the emergency department full time. And between those groups, they would begin to address the gaps that are present for that hospital. When a hospital applies to be a trauma center that is verified by the American College of Surgeons, they have to fill out an application, and this is called the PRQ, Pre-Review Questionnaire. So in the future, if one of the standards relates to pediatric readiness, the hospital would then speak about the approach that they used to identify their gaps and do their survey and how they're going to close those gaps. And I think all of that is a reasonable way for them to sort of start the process. If you can advance to the next slide, which again, I'm not seeing the slides, but one of the gaps I think is that surgeons don't have a lot of confidence in their skills to take care of children. And this then causes them some distress. And I would encourage those of you who are listening to help with building the team that would then support the infrastructure to provide better care to kids, because many of these surgeons are not used to taking care of children and they need your help, especially if they're going to become verified as a pediatric trauma center that's a level 3 or a level 4 in the future. If you could advance, I know many of you are aware that Dr. Macias was awarded a huge grant that will help to develop a regional pediatric pandemic network. And one of the goals is to improve the pediatric emergency readiness of healthcare systems. And that's really what we've been talking about today, because trauma care is a continuum that starts in the pre-hospital arena and then transcends to the emergency department and inpatient settings, or perhaps a transfer to another hospital. But this system of care is what we're describing. And in order for children to be able to fit into it comfortably, people have to be comfortable taking care of them. And the only way to do that is to sort of raise all boats. So we want everybody who might touch that child to have a little more expertise and comfort in doing that. But the team effort, I think, is really essential.
Wonderful. Thank you so much. Looking to see if there's any more questions. Again, please feel free to drop your questions in the chat box for Dr. Fallat. There was something that came through from Patricia Frost. Are there plans for public dashboards and state-by-state national reports?
I think the vision is ultimately that this would be a usable database that officials like yourself would be able to update. But that's something that remains to be seen. I know that some of you will look at your abstract and tell me that some of the data points are incorrect. Well, when you have 88 data points and you've relied on state officials in some cases to give you their opinion, I recognize that some of these data points will probably not be correct, and perhaps they've been updated and we haven't been able to capture that. And so I would love to have this be something that we could work with in real time. So as people update their metrics and progress on this pathway, they will have a comparison, not necessarily to other states, but to their progress. And I think one thing the EMS for Children program should be proud of is that they're not competitive, that we have tried consistently to measure our own progress, but not necessarily to compare ourselves to others. And we work as a team to try to make ourselves better by adopting what others have done and done well. And I hope that ultimately maybe this could be part of that plan.
Wonderful, thank you.